Hello, everyone. I'd like to welcome you to today's echo session on culturally sensitive palliative care for the Chinese community. Today, we are joined by presenter Dr. Kelvin Lou, along with panelists Lennie Tan and Dr. Khue-Tu Nguyen. Before we get into our presentation, I would like to take this opportunity to acknowledge that the land on which I am presenting from, the city of Gatineau, is the traditional unceded territory of the Algonquin Anishinaabe people. I acknowledge the historical oppression of lands, cultures, and the original people in what we now know as Canada, and we are grateful to have the opportunity to be present in this territory. Some of you might already be aware of the Palliative Care Echo Project. It is a 5-year national initiative to cultivate communities of practice and establish continuous professional development among healthcare providers across Canada who care for patients with life-limiting illness. I invite you to stay connected at echopalliative.com to check out any future upcoming sessions. The ECHO project is supported by a financial contribution from Health Canada. Therefore, the views expressed here today are not necessarily those of Health Canada. Many of you might know Pallium Canada for our LEAP content or our LEAP programs, such as LEAP Core, which is an interprofessional course that focuses on the essential competencies to provide a palliative care approach, double accredited by the CFPC and the Royal College. I invite you to check out the Pallium website at pallium.ca to find out more about our LEAP programs. I would like to pass it along now to introductions, but first, my name is Diana Vince. I'm the Palliative Care Echo Project Manager here at Pallium Canada, and I will now pass it along to our first panelist, Dr. Nguyen, to briefly introduce herself.
Hello, everyone. My name is Khue-Tu Nguyen, and I am a palliative care physician at Royal Columbian Hospital in New Westminster, British Columbia.
Welcome. It's nice to have you with us. And Lennie, if you'd like to introduce yourself as well shortly.
So hello, everyone. My name is Lennie, and I am the music therapist here at Richmond Hospital, working in palliative care.
Wonderful to have you, Lennie. Dr. Lou?
So hi everyone, very nice seeing all of you here. My name is Kelvin and I'm a palliative care doctor and I work mostly out of Richmond Hospital and also Surrey Memorial Hospital.
It is lovely to have you with us today, Dr. Lou. So a few welcome and reminders. For comments and introductions, please feel free to use the chat to introduce yourselves. We'd love to hear from you. For questions, please use the Q&A function. The questions will be addressed towards the end of the session. The session is being recorded and a slide deck along with the recording will be emailed to all registrants within the following week after the session. A reminder to not disclose any personal health information during the session. As for the conflict of interest, Pallium Canada is a non-for-profit organization partially funded through a contribution by Health Canada. We also generate funds to support operations and research and development from course registration fees and the sale of the Palliative Pocketbook. I myself, along with the presenter and the panelists, have no disclosures, as you can see before you. And I will now pass it along to Dr. Lou to continue the presentation.
So hi everyone, really happy that we can all be here. This topic is something near and dear to my heart and also I think is quite practical. So let's dive in. So this approach is really based on having a spirit of curiosity and exploration. The way I've looked at it over the years is now that it's not really a problem to be solved. It's really something to be understood. And even though I am speaking some generalities about the Chinese community, we have to understand that even within the Chinese community, there is a huge diversity in terms of languages, traditions, beliefs. So this is not the final word, there's just one more piece of the puzzle. And also, I think the approach is based on kind of our shared humanity and our shared struggle. And although I am focusing on the Chinese community today, I think a lot of the tools we talk about are widely applicable to a lot of people we look after. So I bet all of you, when you woke up today, you weren't expecting to learn about Confucianism, but here we are. So Confucius is a very influential Chinese philosopher, and his philosophy is still applicable today in the modern age. And I think it's helpful for us to understand a bit about the Confucius roots of some of the concepts that we're going to be talking about later on. So one way to look at it is that he saw the fundamental building blocks of society are relationships, be it the ones we have with our families or the wider world. And the problem that he was trying to solve is that how do we maintain harmony within society? And the way that he went about it is that if everyone is playing by the same rule book, in that we all have our predefined roles and duties, that is a way to reduce the friction inherent in normal human interaction, and thereby preserve harmony. So one way to summarize it is that Confucianism is about a set of rules and protocols to promote harmony within society. That's one way of looking at it. Other cultural concepts that's relevant in healthcare is that there often is a preference for collective decision making, where families might prefer having the entire family involved to make a decision. And that goes back to the Confucius roots, where it's about consensus building. You'll notice that I've highlighted certain words in blue, and as the presentation continues on, this is just to remind us of the Confucius roots of these concepts. There's also a preference for something called indirect communication styles, and we'll talk more about that in detail, but generally speaking, a lot of cultures, including the Chinese community, would consider it to be very rude to get right down to business. And there is a certain protocol in terms of how we approach these very sensitive topics, and we'll talk about that. There's also something very important called filial piety, which we'll talk about next. So I think of filial piety as a set of rules that outlines the roles that children should play towards their parents. So, for example, a very major duty and role is that children should look after their elderly parents. And that explains why there's so many multi-generational households within the Chinese community. There also is a heavy emphasis on obedience, where children display their love towards their parents by obeying them and not talking back to their elders. To borrow some of the terminology from Gary Chapman from the 5 love languages, you can kind of think of this as a Chinese love language, where there's a combination of obedience, words of affirmation, and acts of service all together in terms of how people demonstrate their love towards their parents. There's also some strong moral implications for being filial, where going back to the Confucius roots, if we understand that the fundamental building blocks of society is the family and relationships, if you start messing with that, in a way, you are messing with the very fabric of society, and that carries serious moral judgment. There's also a huge societal expectation, where extended families often have very strong opinions in terms of how the children should look after their parents, and that's added pressure into the mix. To give you an idea of kind of the stakes involved, sometimes when I talk to people, I ask them like, okay, like tell me about your life. What are you most proud of? And oftentimes what they'll come back with me at is, it's not so much their job, it's not how much money they made. They tell me, it's like, you know what, Kelvin? The thing I'm most proud of is that I raised my kids right. They are filial towards me, and that is most important. And that kind of gives you an idea of how key it is to some people in terms of their children being filial towards them. So let's dive into a case. We have a 90-year-old female. She has metastatic cancer. Her prognosis is getting short. She's currently living at home, but things are quite challenging. She's had multiple falls, and the family is struggling to provide care despite their best efforts and with maximum home supports. When you talk to the patient, she's refusing to talk about hospice. She's saying, why won't my children obey me? Why won't they respect my wish to stay at home? And I feel like I'm being abandoned to hospice. When you talk to the children, they're also very much struggling, where on one hand, they want to honor mom's wishes, but on the other, they're afraid and seeing that she's suffering at home currently. When you dig a bit deeper, The extended family is also asking a lot of tough questions and having a lot of strong ideas in terms of how the children should behave and what they should do. So the children are in a way between a rock and a hard place. So how can we tackle this situation? One way to think about it is, what exactly is the communication barrier? And that framing will determine our approach. Previously, what I did was that, okay, maybe this is a problem where there's a lack of medical information. So naturally, my approach would be, let's give more medical information. For some people, that will work. And for a lot of other cases, this will not be helpful. Instead, an alternative framing could be, what exactly is the filial duty? And that might lead us to an approach of exploring with curiosity and may offer us an opportunity to provide reframing. So how can we reframe this? So digging a bit deeper into the filial duty, we talked about obedience, but I think there also is an element of protection, where the duty of the child is to protect their mom and dad. That is very much true to the tradition. So in a way, we are expanding the definition of the filial duty beyond just plain old blind obedience to now to incorporate an element of the protection. And by doing this expansion, we now can think about, okay, in this very specific situation, what exactly is the higher filial duty? And that gives us more room to work with. So let's move through each perspective using this new framing. So starting with the medical perspective, initially, it seems like it was a classic case of balancing patient autonomy versus patient safety. But adding this reframing, now we can see it as perhaps, okay, what is the higher filial duty to preserve harmony within the family? Moving on to the patient, she started off from a place of, okay, my children should just obey me, no questions asked, to now it's like, okay, I also have a duty to protect my family. So I need to make a decision that's not just right for me, but makes sense for the entire family. Because it goes both ways. It's a two-way street. For the children, it's like, okay, initially it was, I need to obey mom, and I feel stuck. To now it's like, okay, you know what? Protecting mom is also loving mom as well. And also that is still fulfilling part of the filial duty. And for the extended family, they may have initially started off from a place of being worried about what the children are doing, but as we are now framing this through the filial lens, they understand, like, okay, the children are doing their best, and they are just following sound medical advice, and they're still operating within that filial framework. And that perhaps can help take the pressure off. So that all sounds great in theory, but how does it actually sound like in real life? So here's my pitch. So I'll talk to the patient first here on the left. So to the patient, it's like, okay, Mrs. Wong, your children want to do absolutely everything they can to look after you. They are willing to quit their jobs. They're willing to remortgage their house. They want to do absolutely everything they can. There's no right or wrong decision here. This is really more about understanding the implications of the decisions that we make together. So if I can share the experience of other families, if you decide to stay at home, there are some challenges we have to face. For example, you have to face the fact that once you pass away in that home will forever be the home that you passed away in. And the weight of memory of that is something your family will have to carry on forever. You also have to understand, like if there's grandchildren in the house, their final memory of you could be of you being very uncomfortable. And that is real. At this point, we're also likely thinking about private home support, and that is extremely expensive. So you potentially could have a financial impact long after you've passed on your family. Those are all real considerations. So as the head of the family, can you use your wisdom to make a decision that is right not only for you, but for the entire family? Moving on to the children. Say, okay, I hear what you're saying. You want to do absolutely everything to honor mom's wishes, and I'm here for you. I want to work with you. Whether or not we stay at home or go to hospice, both of these are loving decisions. And perhaps loving mom in this specific situation is not just about obeying her, it's also about protecting her. And I wonder if we can come together and talk about what we can all do realistically to make sure mom is looked after and also she feels loved and supported. So in real life, of course, I don't say that in one breath. It's multiple conversations, but I'm just compressing it for the sake of this case. And let's go through each step in terms of what's happening. So going down the middle column here, the first step is setting up the filial framing. I am working with you. I am looking at the world through your eyes as best I can. Next step is respecting the patient and the family autonomy, because of course we're not being pushy here. We are just trying to understand and help. The next is the filial reframing. I'm trying to expand the definition of the filial duty to beyond just obedience to now element of protection. I'm also invoking the filial bargain, which is a two-way street. It's like, yep, as we all know, with great power comes great responsibility. So the patient also has a responsibility to protect not only herself, but the entire family. The last step is that I am embracing complexity of the situation. Because we start off from a very simple question, hospice or no hospice. But in that way, it's a stalemate. By embracing complexity, I'm asking a much deeper question. How can we look after this patient's medical needs and also make sure that she feels loved and looked after? That is a much more complicated question, but by embracing the complexity and facing it head on, it opens up more options and allows us to have a real conversation. Embracing complexity is a way through. What you'll notice is that I've never used the words filial piety because it's a fairly academic term, so most people will not understand what you're saying, but I described it in words. You'll also notice that I didn't invoke any shared cultural background understanding here, where as long as you have enough trust and rapport with the patient and family, anyone can use these tools. You don't have to rely on the same background. So here's the takeaway. By reframing the filial duty and incorporating an element of protection in it, you're opening up what's considered acceptable options, and you can thereby maintain harmony within the family. And also, embracing complexity. It sounds like it's doing the opposite, but by embracing complexity, it actually gets us into a much more productive frame of mind and getting to really what the patients actually care about. Moving on to some of the tools. So indirect communication is very useful. I think of it as kind of like a spiral shape, where instead of just going right to the heart of the conversation, we are intentionally doing a more roundabout way. We're still working our way towards the center, but we're doing it in a more roundabout way. The function of this is that we are creating space and distance for folks to process what we are saying and maybe understand us a bit better. And also, especially when we're talking about very sensitive topics like goals of care and death and dying, sometimes being too direct can cause trauma. And being intentional and going a bit more slowly can help folks process that grief and trauma. Understand the culture element. In many cultures, like the Chinese community, it can be considered extremely rude for you to just go right down to business, especially for something this sensitive. So being more roundabout is actually paying dividends, and actually is perhaps the most efficient way to do things. It goes back to protocol. There's a protocol and rules in terms of how you talk about things. And if you break protocol, you might not be listened to. Adding on to the spiral metaphor, I think of this sometimes like the very contentious family meetings as almost like a storm. There's like a storm raging. So what do? Like, do you fight the storm? Do you fight the force of nature? Or do you go with the flow and go in the spiral shape? You're working your way towards the center in the eye of the storm using these indirect communication techniques. And by doing that, you can get to the eye of the storm, which is perhaps the emotional core of the conversation. And in that place, there could be a moment of quiet. You finally can hear what the genuine concern is and tap into that emotional energy. And that can transform the case. Moving towards the eye of the storm. That's often how I characterize my work. More tools. You can also use celebrities and public events to talk about goals of care. Because for a lot of people, talking about their own impending mortality is just way too direct. It's too painful. So why not use a public figure to talk about around it? For example, Prince Charles has been in the news about getting diagnosed with cancer. So you can use him. It's like, okay, he has cancer. What do you think about that? What do you think is important for him? And how do you see serious illness? How do you see someone being hospitalized for a long time? What do you think about that? But not talking about them, but talking around it by using public figures. That can be a way through. We can also communicate prognosis functionally, which is indirectly talking about it without having to invoke numbers. Because culturally, for a lot of people, by talking about death directly and giving numbers, you're almost invoking bad luck. It's very taboo. So why not just talk about it functionally? So for example, like Mrs. Wong, like when people are not really eating and drinking, they are sleeping the entire day, they're bedbound, that's when I know roughly that they're starting to enter that final part of the journey. So I've basically described in words a PPS of 30%, but I never gave them a number. But it's a very intuitive, indirect way for patients to gauge where they're at in the spectrum. Other tips. Oftentimes we're using a translator, and it can be helpful to note down the good translators who have good rapport with the patient. And they often have their own translator ID. And what's happening there is that I am piggybacking on the translator's good rapport with the patient. So if they have a good relationship already, I am using their rapport to communicate our message, and that can be so effective. Getting even more creative. So let's say, and this happens to me not in often, I walk in, it's like, hey, I'm Kelvin, I'm from Palliative Care, and I might get fired on the spot because they don't want to talk to me. What do? Why not instead plan to talk to their roommate in the same room in the hospital? So I will talk to the roommate, and I'll do it in a way that respects patient confidentiality, but I'll talk in general terms what palliative care is about. I'll talk in general terms what hospice is about. So the patient that I actually want to talk to, they feel less threatened, perhaps their defenses are down, they're just listening in. They're listening in the conversation, and they can perhaps absorb and process it, and then I'll take another shot a couple of days down the road. It's like, hey, I come in peace, can we talk? I'm just trying to here to help. Once you have this indirect communication tool in mind, the sky's the limit. You can get very creative in terms of how you communicate indirectly. Other things. I think it also is helpful to think through the symbolic value of intervention, what it means for the patient. So something that comes up very commonly is artificial hydration and nutrition, feeding tubes, IV fluids. Thinking about what the food symbolizes could be very helpful. An example of this is like, okay, Christmas dinner is very meaningful to a lot of us. And oftentimes, it's not just about the Christmas turkey. It's about breaking bread with the ones you love. It's about being surrounded by the people you care about. That's what it's about. And it's that symbolic power that matters, not so much that we're eating food. It's what it symbolizes that matters. And that can be applied for our patients too. So for example, in a variation of the Buddhist belief, there's something called a hungry ghost. So it's the belief that if someone dies on an empty stomach, they get into the afterlife as a ravenous spirit. Here's an excerpt from a patient family explain what they think. This is the worst kind of ghost. He dies with an empty stomach. He will not have what he needs in the afterlife. He will keep coming back to the house. He must die with food in his belly. So with that context, we now understand that it's not really about the intervention, it's what it symbolizes. And you can see that if the family has this hungry ghost framework, you giving a physiological answer to why you don't recommend a feeding tube is not going to make a ton of sense. You need to get to the spiritual, emotional core of the conversation. Adding on to that, narratives and story are very powerful. And I really love stories to communicate because it engages in a real back and forth dialogue and avoids debate. Debate is when we're trying to win, we're trying to debate about facts. It gets into a very unproductive place. For example, think back to a time where you personally changed your mind on something that's very important. What happened? I would wager it wasn't because someone debated you and destroyed you with logic. It's most likely you heard a story that moved you and then you changed your mind. Same thing here. Stories allow us to not only convey information, but it gets to the meaning behind the information, which is so key. And let's think through what stories are available. I think a very powerful story is the story of the immigrant, which in my mind is our parents sacrificed so much so that we can have a better life in the new world. Let's see how we can use this story to enhance communication back to case 1. So for example, you're talking to Mrs. Wong. It's like, okay, you're hearing about the story. And if you hear the immigrant story from her story, that can be an opportunity to add to the story. It's like, okay, Mrs. Wong, it seems like the through line in your story is that you sacrifice so much for your family. I wonder, can we perhaps see the decision around hospice as perhaps being part of that story? Does that resonate with you? So with that, perhaps we can reframe the story, where initially we started from a place of a story of abandonment. My kids don't love me, they're dropping me off in hospice, to perhaps shifting it to a story of heroic self-sacrifice, where it's like, yeah, I don't want to go to hospice, but I am sacrificing my own personal preferences for the sake of my family. Huge implications. Because speaking of stories, endings matter. They matter so much. Where the first story, the ending could be where, like, you think about what story will they tell on the anniversary of this patient's death? Would it be the first story where it's like, you know what, mom ended up in hospice and she died brokenhearted up to the very end, and I carry tremendous regret because I let mom down? Or could it be the second story where mom loved us so much that she was willing to sacrifice her personal preferences for us? That's how much she loved us, even though she didn't want to go to hospice. That's a dramatically different ending. And the ripple effects of that echoes on long after the patient's passed, where depending on how you swing it, the story can either be a tremendous regret or it can help the family heal from their grief. The endings matter so much. I'm making this sound very simple. In real life, this will take many conversations. But I think if we have the opportunity to shift the story, it is worth it because it can have a dramatic change for the family. Another case. So we have another 9-year-old female. She already is in hospice, and the family's asking us about whether or not we should start IV hydration and insert a feeding tube. There's been multiple aspirations and the family's still feeding at risk. What do we do? So let's use our standard approach. Absolutely explore the underlying goals. Absolutely explain the physiology and the evidence behind the risks and benefits of inserting a feeding tube in this situation. And now let's add in some of our tools where, okay, what exactly is a filial duty? Thinking through the protection aspect of the filial duty. Early on in the clinical course, when the patient's stronger, we think of the protection as life prolongation, where we protect our family by extending their life. As we get to the end of life context, you could potentially reframe the protection as the prevention of suffering, where we protect our families by not giving them interventions that can hurt them. That is the protection. Also, perhaps explore whether or not the extended family is putting undue pressure on the child and the patient. And sometimes what I'll do is that I'll offer to call the extended family back in China, long distance, and I'll tell them directly, it's like, look, the children are doing the best they can. And this situation about not inserting a feeding tube is coming from me as a medical recommendation. It is not the children's idea to withhold care. They're just listening to medical advice, and they're being filial in their own way. That could help take the pressure off. thinking through the story and also thinking through what the intervention symbolizes. Could this be a hungry ghost situation? So a solution could be that we use those sponge lollipops to use that and dip it in D5W and use that to do mouth care. And what's happening there is that theoretically, there is some dextrose getting into the stomach. So through that sense, if we understand the symbolic value of that, we are fulfilling the spiritual religious requirement of not being and having an empty stomach. And also we are balancing that with the medical needs where we are afraid this patient is at high risk of aspirating. By understanding the emotional core of the conversation, understanding the symbolic nature of the food, it offers us more options. Embracing complexity gives us more room to play with. The takeaway is it truly is not about the intervention, it's not about the disposition. Oftentimes, over-focus on the intervention is actually a red herring. Where the work needs to be, where the real conversation needs to be, is actually the emotional core of the conversation. That oftentimes can help you understand a case in a way that can move things forward. So important. Another case. Now we have a 30-year-old. They have metastatic colon cancer. Their prognosis is shortening, and overall, they're having a great functional decline. They're coming to hospital for an ongoing GI bleed that we can't stop. He's a refugee, and he's new to Canada. When you talk to him, he understandably is very treatment focused. He wants to be transfused. And he currently is still full code, despite many, many conversations. What is his story? For me, his story is summarized by the picture on the right-hand side here. The caption for this story, this picture, is that on my shoulders, responsibility. In my hands, hope. And I think that's kind of the crux of the story. This is a story of hope, where this man has tremendous hope. Without that hope, he would have died in his home country. He wouldn't have made it here to Canada. And hope is something that gives him tremendous strength. So now he's in Canada, and he's sick. He needs help. How do we look after him? Do I call ICU and make him DNR against his wishes? That thought crossed my mind, but it felt wrong to snuff out his hope. So let's use some of the tools that we talked about to unpack this case. What does medical intervention symbolize for him? As I got to know him and learned about his story, he told me back in his home country that he couldn't access even basic medical care. And part of his trauma was that every single time he comes and talks to a doctor, they say no, 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 no. So when I start talking to him about, okay, let's think about hospice, or I start talking to him about less is more, and about the risk of over-intervention, all I was doing was re-traumatizing him. That's all I was doing. Let's also think about what is the definition of a good death. From my training, a good death is no IVs, no transfusions, maybe death in hospice. I think that perspective is valid. What I had to learn, though, is that that's not the only perspective. And for him, where he's been deprived of so much, where he's had to fight for everything he has, his idea of a good death is receiving full medical support up to the end. That's how he feels looked after. In his case, less is not more. It does not apply. More is more. Knowing this, how can we look after him? It goes back to the story of hope. His hope is to die in hospital with full medical support. And because I showed a willingness to listen to his story and his hopes, he became eventually open to hearing my hope, which is that I really don't want this man to die languishing in ICU, sedated and intubated. And we met in the middle. We ended up meeting in the middle, where we looked after him with full medical support, IVs and transfusions, and we decided together not to pursue CPR and intubation. How we got to this place is not because I said some magical words and changed his mind. What happened was that because we both got into a real dialogue and we heard each other's stories, we merged our stories. And it allowed us to move from the initial story of deprivation, where the system is once again failing me. You are yet another doctor saying no to me, to the story of a new hope. We merged our hopes together and we created a new one. The patient and I created something new together. And that's how we arrived at that place. It truly is not about the intervention. It's not about the IV. It's not about the transfusions. It's about the human story and the goals. That's where the conversation needs to go. So what happened? In the end, he passed away in hospital. And we transfused him right up to the week he died. It gave his family and him tremendous peace, knowing that he was supported right up to the very end. And I do think that because we were able to meet him where he was at, even though he died, it was the foundation for the family to heal from their grief because they felt supported. The tough question is this a good use of medical resources? I don't know. I think for all of us, we each have to decide what is a good death and what does good care look like. I've shared with you what I did in this situation. What would you do in my shoes? That's the key question. The takeaway is it really is not about like using all these fancy techniques and like playing mind games. It really comes down to the relationship you have with your patient. As Dr. Irvine Yalom would say, it's the relationship that heals. It's not about what's going on here, it's more what's going on here. And also, it's not so much about trying to change a patient's mind. How we got to that place in that case was that I changed myself first. I was trained in a very specific way, and I opened myself up to hearing a different perspective in terms of what's a good death, what's good medical care, and because I opened up my own mind, the patient was able to tell me his story, and I was able to hear it. That's what changed in the case, not me forcing my worldview on this patient. We created something new together, and that can be very powerful. I love this quote. It's from Dr. Elizabeth Gruber-Ross. She's the person who came up with the stages of grief model. If you want to deal with the dying, deal with your own stuff first. I think this rings true, and I think about this quote often. If we don't process our own baggage, if we don't interrogate our own biases, how can we look after people who've lived a very different life from us, who come from all over the world? It's so important. This is key. So, in summary, I think it really comes back to our common humanity and our shared struggle. That's where all this stuff comes from. Yes, there's cultural elements to it, but it really comes down to, can you connect with the patient on a personal level? Even though you guys come from a very different background, we all believe in different things, can you have a personal connection with this other human being? That is the basis for a real dialogue. We've talked a bit about how we can reframe the filial piety and the filial duty, and how that can open up more options that are acceptable to family. Adding this framing is so helpful, where we can break a stalemate, where we're thinking too simplistically. We are embracing complexity, and that opens up more different options. We've talked a bit about using indirect communication, Again, the sky's the limit. There's so many ways that we can adapt this strategy of communicating indirectly. And yeah, tell their story. Hear their story. The story is so powerful, not just as a means to change someone's mind or change the patient's mind, but to change our own. I heard that man's story and I was moved, and then my mind changed. It's about changing ourselves. So at this point in the presentation, if you feel like this is like overwhelming, way too much, in a way, I get where you're coming from. It's a ton. And the only way that we can do this work is as a team. It truly takes an entire team to adopt this approach. No one person can do all these things. We have to come together. And that's how we do it, as a team. Each of us sharing the burden and trying to build that connection as a team with the patient and family. There's a really lovely movie called The Farewell that I highly recommend. It goes through a lot of the themes we talked about. I won't spoil it for all of you, but the general gist is that the main character is Aquafina. She's an American-born Chinese person. She lives in America. And she hears that her grandma, living in China, has a new diagnosis of cancer. What do we do? So she goes back and flies back to China, and the whole story is about the cultural clash, the Western worldview and the Chinese worldview, and how they navigate that. I think this story is so beautiful in that it does justice to both perspectives. Because it's not about who's right, who's wrong. It's about how do we make sure grandma is looked after medically, and also how do we show that we love her and we want to look after her. That is the heart of the conversation, and I highly recommend this movie. With that, thank you for your attention, and yeah, open to any questions or thoughts from anybody.
Thank you so much, Dr. Lou, for such a comprehensive presentation, and your cases draw from great experience of examples. I'm looking at the Q&A. I don't see any questions just yet, but we do have Manuel Luis Capella from Portugal, who just put into the chat that very engaging. He learned a lot about the Chinese community, the different perspectives about successful communication was gold. Thanks from Portugal, where we have an important Chinese community. So as a feedback, we also had another feedback in the Q&A actually, that, they've learned a lot. I believe it was from Sonia, learned a lot during the session. If anyone has any questions, by all means, feel free to, you can unmute, or you can just throw it into the chat or into the Q&A. Olivia Bauer says it was an excellent presentation as well. Cindy Lalonde says this approach is indicative of patient-centered care, embracing sincere compassion and empathy. The presentation is related to Chinese community. Could we not embrace the mindset to all our palliative patients? I would say so. A copy of the recording is going to be available about a week following the presentation today. So it's going to be sent to all registrants, Katrina. Jenny is saying very helpful examples explaining the ways that you approach culturally sensitive palliative care for anyone, or really even those specific to the Chinese community. We have a question that just appeared in the Q&A from Avalon Harris. It's not a question. Wonderful presentation, thank you. I'm a music therapist. Would love to hear anything important to know about music at end of life. Maybe we can have our one panelist, Lennie, join in on that.
Hello. So who was this again? I didn't catch the name.
Oh, this was from Avalon Harris.
Avalon Harris. Hi, Avalon. So, again, as Kelvin was sharing, it's like, again, as a music therapist, first we have to listen. We have to build that relationship. We have to understand where the person we want to care for is coming from. So with music, it's such an individual thing. For some people, I found that especially with our Chinese community, music is not necessarily what they would want at the end. And for others it is. So again, it is such an individual thing, and for each one it takes, sensitive exploration with the person. There's a lot of conversation, a lot of trying to understand, and doing what supports not just the person, but as with the family as well. I find that I tend to work a lot with family. So with the patient might not be, wanting music at the end, but the families one would like that. So just expanding beyond the individual. I think again, from an Asian perspective, we don't treat just the individual, but it's the whole family. And I think here in Richmond, that's how we tend to practice, right? Trying to see how we can support everyone there. Yeah, thank you.
Thank you, Lennie. I also have a question in the Q&A. There's a few that are trickling in from Danica Hans. I would love to hear your thoughts on opposing ideas I picked up from your presentation. On one side, recognizing my bias and recognizing that there are many right ways and no single good way to care, versus using indirect communication to get to a specific recommendation or course of action.
Great question. Great question. I don't know if they can see my answer. I just pasted something in there. But kind of, this is a Sufi poem, which I love. It's like, out beyond the ideas of wrongdoing and right doing, there is a field. I'll meet you there. And that's kind of what we're talking about when we're talking about story. That's the power of the narrative, is that the story is not about like a right or wrong. It's like, I'm sharing with you my story, which is I'm trained in the Western tradition. I trained here in North America. I believe certain things and I feel great conviction about the mission of palliative care. And also, the story creates space to hear other perspectives. And that's kind of the difference for me, and the beauty of the story is that I can feel strongly about certain things. I work in hospice. I love hospice. I believe in hospice. And also, I'm not saying that I'm right. It's more just sharing my conviction. And please, you share your conviction too. And together, can we merge our stories together and find a new story, a new place? I'll meet you there. I think that's kind of how I see it.
Wonderful. Gloria Huang says, did you get pushback from the rest of the staff in keeping the refugee patient on relative high-level medical treatment? And if so, how did you deal with it?
And tricky, and I welcome either Lennie or Khue-Tu to also share their experiences, because it depends on where you work. I am very fortunate that I work with my fellow colleagues who think quite similarly and also want to respect different perspectives. But absolutely, depending on where you are, you absolutely will get pushback, and that's reasonable, because there's not really a right answer to this question. It's such a complex question. And kind of how I would tackle that is, again, to understand their story. Because like that mutual understanding we talked about is not just about us and the patient. It's about just human beings overall, including other healthcare folks. It's like, look, I want to tell you about this young man who's dying, and he's a refugee. He needs this to feel looked after. Can you help me? And tell me what you think. That mutual understanding extends to the whole medical team. And if I feel like sometimes because of our training, we're biased to think in a certain way, but if I can tell them a genuine human story and then ask for help, please give me access to these resources, that can start a conversation. It might not solve all problems, but you might learn something on both ends, and that might be the way through.
From Miralini Sivanathan, we have loved the presentation, a very practical and good way to reframe our thinking. Wondering if you could give more practical approaches and language on bringing up topic of children, thinking about withdrawing care, whether there are two children and one is wanting to withdraw and the other is not.
So again, Lennie and Khue-Tu, feel free to chime in because I feel like I've talked too much already. I'm getting tired of hearing my own voice. But Yeah, that's a tough one. That is a very tough one. And it goes back to the harmony, the Confucius concept of harmony. The harmony is being disrupted, and I bet you the patient themselves is likely experiencing tremendous distress from that, sometimes more than the actual illness. It just seeing the family in discord, that hurts them deeply. What do we do? I think the filial aspect is something that can be explored. Oftentimes, in these situations where there's different viewpoints, where we're disagreeing is what is good, what is the duty in this situation, where one end of the family is saying the filial duty is maximum life prolongation. That's our duty. The other end is like, no, the protection duty is actually to reduce suffering. That is the tension. How we can facilitate this is to bring that up to the surface. Because oftentimes in a medical setting, there's so much going on, so many moving pieces. It's like, okay, like forget about all this like intervention stuff for a second here. Let's talk directly about what do we see as the filial duty. I hear what you're saying on one hand. Protection is about life prolongation. On the other, I hear protection is reducing suffering. And bringing the conversation back to that human element, that can move the conversation forward, where they can talk more openly about why they think the filial duty is that. That can help move the conversation forward. And it, again, it's the red herring of the intervention. If we can only move it back to the human piece, kick the conversation down that route, that can end up opening up more avenues and not make one party feel like they're being accused of not loving the patient.
Yeah, thank you.
May I jump in there also? You know, we've recently had a situation on our palliative unit where the children were not in accord. So the father and the son were wanting to do everything possible for the mother, and the daughter was seeing that the mother was declining and suffering and was, you know, opening up to palliative care. And, you know, so conversations were had, but what I've realized was so important was for all the voices to be heard. So we had to hear from the son, the husband, the daughter. So each one was heard, and then separately before we could even come together. Because in the beginning, it was like nobody could hear each other. So I think just providing that understanding and that space seemed to have worked. Thank you.
This doesn't directly answer the question about one child wanting full medical care and the other not, but I do have a story that draws on similar themes that touches upon the harmony aspect that Kelvin talked about and the story aspect, and also the mutual understanding piece that Lennie brought up. In a similar way to the question that was posed, there was a Vietnamese family who were refugees who came over to Canada, and one child wanted full medical care. The other child wanted his father to be taken care of in hospice. So very different, and they all had full understanding of what hospice care entails, and there's no misunderstanding with that. The father, i.e. the patient, was kind of split as well, and so couldn't decide and was trying to listen to both arguments. And so as I got to know this patient's story, I learned that he had come to Canada as a refugee, as a boat person. He had to, because there were situations that or circumstances that he couldn't control in his home country due to a war, due to the end of the war and the regime that was there. He couldn't control that. He had to protect his family, like Kelvin was talking about, find a new home. And that new home is Canada. And now that he's entered this new phase of life, where he had, I forget which cancer it was, he had to think about a new home. That, again, similar themes. circumstances you can't control, which is the progression of cancer. What is your new home? Potentially hospice. And that was his way of taking care of his family, which is to help his families be able to navigate at home and with him in hospice. So after we, as a family and the care team at the hospital, talked about this story and how important it was for him to feel like this is part of my story. I've had the strength to move my life across the ocean. Here it's across the city. His other child who wanted full medical care said that is definitely what my father would want. And so I don't know if that fully answers the question, but I think I'm not saying anything new. I think everything I just mentioned in that story, in an attempt to answer that question, draws upon the various concepts that Kelvin and Lennie have already spoken to.
Thank you so much, Dr. Nguyen. I'll ask, there's two other little inquiries in the Q&A, and then we're gonna pass along to the wrap up. From Sarb Basra, do you have a Chinese cultural informed palliative care social worker who works with you? All these values align with many communities, cultures, as we know. Thanks.
Yeah, I'm lucky. I'm very lucky in that I do. And I think um, it. I think the palliative mission aligns great with the social worker mission, which is like social justice. Like all the stuff we talked about is very social justice oriented. So even though the terminology might be slightly different, once you get to the core of it, the human element, I think there's huge commonality and parallels with it. So yeah, I think having this framework we talked about is helpful, but the deeper aspect, I think many disciplines tap into that.
Okay. And do you have any educational sheets for your staff on cultural care for Chinese community that you are able to share if you do? I can always
I'll dig
also,
around. Yeah.
what I'll do is when we share the follow-up email with the recording, we can also include any resources. So thank you to Sarb for mentioning that. And he or she also added, our experiences of healthcare from our home countries informs our expectations of healthcare as well, in addition to cultural ADN personal expectations. Simply as a final
Hmm.
remark.
Hmm.
Oh, I think this session definitely has left everybody to think about these such important elements. I'd like to take this opportunity personally. Thank you, Dr. Lou, for joining us today to shed some light on this, along with our two panelists, Dr. Nguyen and Lennie Tan as well. A little link has been added into the chat. We'd always love to hear what you think about our sessions. So it's the time for us, for you to give us your feedback. Our presenter would love to know as well. Don't worry, the surveys are completely anonymized. And a recording along with the slide deck will be shared in about a week or so with everyone who registered. So if you joined us here today, we already have your emails. And if you registered, whoever registered and couldn't make it, will be able to have access to the session as well. Once again, thanks everyone for joining us today. And have a wonderful rest of your afternoon if you're out in BC, and if you're anywhere else on the eastern part, have a wonderful early evening. Thanks, everyone.